Let's take a look about the pathophysiology of hepatic encephalopathy. Hepatic encephalopathy is a deterioration of brain function caused by liver failure. The nitrogen-containing chemicals produced by gut bacteria are either expelled or carried into the liver via the portal vein, where they are largely processed by the urea cycle in healthy patients. Cirrhotic patients' hepatocytes, on the other hand, do not operate properly and are less capable of metabolizing waste products. Shunts may arise as a result of increased portal pressure that allow blood to flow from the portal system to the inferior vena cava. The issue is that this blood includes ammonia, which is a nitrogenous molecule. It can cross the blood-brain barrier and is produced by astrocytes, as glutamine is produced from glutamate. As a result, increased glutamine production raises the astrocyte's oncotic pressure, causing it to swell. Mercaptans, short-chain fatty acids, and phenol are some of the other chemicals involved with hepatic encephalopathy.
Overt hepatic encephalopathy is diagnosed based on clinical findings and by excluding other causes of altered mental status. The most common disorders to consider in the differential diagnosis of overt hepatic encephalopathy are medication-related adverse effect, severe electrolyte disorders like hyponatremia and hypercalcemia, rheumia, systemic infection, central nervous system infection, psychiatric disorders, alcohol-related disorders, intoxication in withdrawal or Wernicke-Korsakoff syndrome, hypoglycemia, hypercapnia, non-convulsive epilepsy, and intracranial bleeding or stroke. According to an article that I have read, medical therapy use is basically non-absorbable disaccharide. The stages are divided into three. Firstly, initial dosing, next maintenance dosing, and lastly management of persons who become comatose. Other than that, antimicrobial therapy to alter the gut microbiota to create a more favorable microbiome that result in lower endogenous bacterial production of ammonia is used. Rifamycin is now the preferred antimicrobial agent for the treatment of overt hepatic encephalopathy. Other than that are neomycin and metronidazole.
Next is the nutritional consequences in hepatic encephalopathy. The biggest nutrition concern is malnutrition. However, we could break it into few causing factors to help us conduct a more specific intervention plan for the patient in terms of their dietary requirement, meal modification, supplementation, or consideration for EN and PN nutrition. For example, patients could experience inadequate dietary intake, malabsorption, GI bleeding or discomfort, hypermetabolism, insulin resistance, ascites, or hyponatremia that could all affect their dietary intake.
Next is the nutrition assessment usually performed on HE patients. For anthropometry, usually these three parameters, which are weight changes, and BMI, are used to assess malnutrition, since malnutrition is common in hepatobiliary disease. However, these three outcomes may be affected by ascites or edema. Hepatic encephalopathy may cause certain biochemical abnormalities such as hypoalbuminemia, thrombocytopenia, hyponatremia, and hypokalemia. This disease may also increase certain biochemical value which may cause hyperammonemia, high levels of AST and ALT, and hyperbilirubinemia. Hepatic encephalopathy may also cause physical changes which are usually examined through the use of SGA form, which may result in findings such as muscle wasting, fluid accumulation, taste changes, and GI problems. Mental status grading are usually assessed using West Haven criteria or Glasgow Coma Scale, while malnutrition can be examined through physical measurements such as MAMC, MAC, TST, and hand grip examination. In patients with HE, normally the dietary intake is assessed on its adequacy. It is important for HE patients to consume enough energy and protein. They should avoid taking too much sodium to avoid fluid accumulation, and HE patients are usually prescribed with lactulose.
Here are some common nutrition diagnoses for hepatic encephalopathy. First is unintentional weight loss related to protein energy malnutrition as evidenced by physical finding of muscle wasting. Second is inadequate oral intake related to GI discomfort or pain as evidenced by loss of appetite, nausea, or early satiety. Third is impaired nutrient utilization related to fat malabsorption as evidenced by steatoria. And fourth is altered nutrition-related lab values related to hepatic encephalopathy as evidenced by hyperammonemia, hyperglycemia, or hyponatremia.
Now, let's move to nutrition intervention. 20 to 40 kcal per kilogram body weight will be prescribed depends on patient's nutritional status. 1 to 1.5 gram per kilogram of protein will be prescribed depends on patient's BMI. In moderate and severely malnourished patients, initial protein prescription should start at 0.5 gram. For carbohydrate, 40 to 60% of DI is prescribed and complex carbohydrate should be included. Lastly, for fat, 25 to 30% of DI is appropriate for HE patient. What is the objective for nutrition intervention for HE patient? We can see there are 3 long-term objectives and 2 short-term objectives listed here. Let's discover nutrition strategy shortly. Firstly, encourage small and frequent meals for HE patient. Second, HE patient is suggested to consume plant-based protein. Next, casein-based diet such as milk and cheese is encouraged for HE patient. Fourth, acute HE patient related to cirrhosis is encouraged to take probiotics. Lastly, alcohol must be avoided at all costs. Enteral and parenteral nutrition are advised for grade 3 and 4 HE patient due to neurologic coma. In the last part, we will see what will be monitored and evaluated for HE patient. Weight changes, daily intake, tube feeding tolerance, and biochemical data will be monitored and evaluated.